Okay, thank you. So, good morning, everyone. I welcome you all in this trauma module. And for today, we are going to talk about difficult supracondylar fractures. And my friend, Dr. Venkatdass, we all know him, and he is belonging to uh, one of the busiest pediatric trauma center of India from Ganga Hospital. So welcome, Venkat, and we all are looking forward to hear you. Yeah, Preksha, you can take over and introduce Dr. Venkatdass.
Yes, sir. Good morning, everybody. Dr. Venkatdass is the head of Pediatric Orthopaedic Division at Ganga Hospital. After completing his basic training at KMC Mangalore and receiving his training in pediatric orthopedics, he went on to do his fellowship at Rady Children's Hospital, San Diego. He has received many prestigious awards, as him and his team have won Eurospine Award in 2008, got the IOA Young Ambassador Award in 2016, and IOA Silver Jubilee Oration in 2018. He has received multiple medals in many national conferences and has n number of publications and chapters in multiple books. It is a privilege to have him here. So kindly take over.
And
Thank you, Preksha.
one more thing, Preksha, I must tell you is Venkat is doing phenomenal work in hip preservation, and
Yes.
we have an opportunity to learn lots of things from him as far as the SCFE and adolescent hip is concerned. So welcome, Venkat.
Thank you, Preksha, for the kind words, and thank you so much, Maulin, for having me here. It's always fun to teach. So today we are going to see about atypical supracondylar fractures. I think last week you had a very nice session on basics of supracondylar fractures.
Yeah.
So we'll start with what do we mean by atypical supracondylar fracture. Unfortunately, we do not have a textbook definition of an atypical supracondylar fracture. So when we see routinely a lot of typical supracondylar fractures, we know that the apical ones will stand out, which is different from the normal supracondylar fractures. So for that, we need to define what do we mean by a typical supracondylar fracture. So I've taken three things into account. One is the most common type, which is an extension type. And the second point is, which is easily reducible. So this can be subjective, but I'm sure most of you have come across this, a grossly looking displaced fracture. Also, you can just manipulate and it just falls back in position. So that is what I mean by easily reducible fracture. And it should be be able to be stabilized with the standard pin of two lateral divergent pins. So if these three criteria are satisfied for me, it is a typical supracondylar fracture. So it's a straightforward fracture that can be easily reduced and stabilized with two standard lateral divergent pins. So let us look at this one. So this is like an 8-year-old boy with a grossly displaced supracondylar fracture. Looks really scary on the first look, but then when you try to reduce and pin it, this is like a cakewalk. You get the reduction in 5 minutes and the whole procedure is over in 10 minutes. So this is a good example for a typical supracondylar fracture. So let's move on to atypical. So these are all the various things which I could think about when you think about atypical supracondylar fractures. The first category is rotationally unstable fractures. The second is medial oblique or reverse oblique fractures, which you cannot pin through the standard techniques. Third category would be those fractures associated with comminution. And if you have any associated fractures, intra-articular extension, flexion type, though rare, they are atypical. And last is very low supracondylar fractures, which can be sometimes challenging. Pulseless, I'm not going to discuss this particular session. So let's move on to rotationally unstable. So this is a 12-year-old boy with a posterolateral fracture, supracondylar fracture type 3. You can see the hematoma on the medial aspect. So we attempted to reduce and fix it with two standard lateral wires. And I always tell my fellows that you should, after pinning, check both the oblique views. This is an external rotation and this is an internal rotation. Oftentimes you will find that when you internally rotate, you see this spike anteriorly. And I'm not happy when this happens. This is a rotationally unstable fracture. So we used the derotation wire to rotate it back and then place the medial pin. And after doing this, you can see that the fracture is completely stable both in external rotation and internal rotation. So these are rotationally unstable fractures, which you can stabilize with the third lateral pin. But my personal preference is to add on a medial pin because it works well.
So
The second category of
Venkat,
fracture is,
can I
yeah,
just can you go back? Now, can you
yeah,
guide
yeah, yeah, sure.
how to put this? I saw that you have placed this wire from the lateral side. So what is the technique that you are avoiding
Yes.
radial nerve while putting this wire?
Yeah, this was one of the earlier cases I've gone really up. I'm going to come to that. It is there in my subsequent slides, how to
Okay,
place the
okay,
lateral wire, where to. I have the slides with me. So we will discuss about that,
okay.
right? So this second group of fractures, or what I call as reverse oblique fracture. So we have to understand that all all supracondylar fracture does not have the same configuration. You would have come across various classifications which was described in the last session. So this is the reverse oblique fracture, which cannot be pinned by two lateral wires. So you cannot get a stable fixation with two lateral wires. The fracture line runs proximally on the medial side and goes down distally on the lateral side. So this will need a cross pinning. So this was what was done. So cross pinning was done, and this is the 4 weeks post-op. So can you get away with this fracture without doing a medial pin? So it is possible. You can stabilize the medial column from the lateral side. So that pin is called as Dargan's pin. So that is your standard lateral pin, which goes from the lateral side to the medial cortex. And from the proximal side laterally, you can go on to the medial side. So this configuration again gives you a cross pin configuration, but you're completely avoiding the medial side and you can safeguard your ulnar nerve. So this pin is called as a Dargan's pin. This was first described by Mr. John Dorgan from Aldehay, but was published by Shannon and his colleagues in 2004. And they did not have any complications in a set of 20 patients, the initial publication. But later on, there were papers which said that you can hit the radial nerve when you're coming from proximally. This is what exactly Moulin was asking about. When you put the derotation pin, what is the safe corridor? So Sangeet from Vellore has done a good cadaveric study to look at the course of the radial nerve on the lateral side. And this is what it looks like. And he says that the safe corridor is just 1 centimeter proximal to the intercondylar line, and you come from the posterolateral side to the medial side. So posterolateral is the farthest away. So that is a safe corridor for you to get the pin, both the Dorgan's pin, as well as whenever you are planning a derotation wire, which I showed in your previous case. So you go as distal as what, just 1 centimeter above the intercondylar line is the safe corridor. But sometimes your fracture configuration might be demanding a slightly higher level, but this is the usual level which we plan. So this is another child, again a medial oblique fracture, a reverse oblique 3-year-old child, which we pinned with a medial wire and two Dorgan's pins from the lateral side to the medial column. And that's how it healed well in 3 weeks. And this is the 2 years follow-up of the same patient.
So Venkat, what is the
Moving on to the
intercondylar
next.
what is intercondylar line? Can you show it on X-ray? What do you mean by intercondylar?
I think I take it as the upper border of
Olecranon
the
fossa?
olecranon fossa. That's what I do routinely. So the fracture most of the times is just above the olecranon fossa for us. So if you go 1 to 1.5 centimeters just above it from posterolateral, then it is
Okay,
a
then it
safe
is safe.
corridor.
Okay,
Yeah.
thank you.
The next set of fractures is fractures with comminution. So these days we see that high violence injuries are not in any age group in children. We do see patients like 2 years, 3 years with comminuted distal humerus fractures. You can have comminuted fragments in either of the areas, be it anterior, posterior, medial, or lateral. But anterior and posterior comminution does not matter as such. But when you have a medial or lateral comminution, it really matters. So we need to understand this concept of two columns, medial and lateral column, and the capital along with the trachea forms the tie arch. So the main idea of pinning a supracondylar fracture is to prevent a varus deformity. So a small comminution on the medial column is all that it takes to produce a bad deformity. You have to understand this concept. So I will share two different cases, so which was treated conservatively. The first case is a 4-year-old child. You can see the X-ray looks very innocuous. It was treated as a type 1 supracondylar fracture. This is a courtesy of Dr. Sandeep. And the case on the right side is a 2-year-old girl. Again, it was treated as a type 2 supracondylar fracture. Conservatively, the surgeon decided to treat it conservatively. And you can see that in 2 months' time, it led to a really bad looking varus deformity. So, though the fracture is very innocuous, it can lead to a bad deformity if you don't treat it appropriately. You have to catch them and pin them. So what really went wrong in these two fractures? So if you take a closer look at this fracture, you can see that there is a small comminution here on the medial side. You can see the same fragment in the lateral view also. So this is a danger sign for us. Whenever you have a medial comminution, this is going to progress into varus. On this X-ray, this is a type 2, the medial comminution. On the right side, the comminution is not very prominent. If you look very carefully, you can see that there is a small fragment. It's but there is sort of a buckling and a varus alignment of the distal fragment. Again, this is a danger sign. So I am a little more aggressive in pinning these type 2 fractures with medial comminution and or a medial buckling. So you have to understand that in certain situations, the benefit of a single medial pin outweighs that of a n number of lateral pins. So these are the fractures which definitely need some medial column stabilization. So how to place a medial pin very safely without injuring the ulnar nerve? Whenever you need to place a medial nerve, you should learn this technique. This is a very nice paper from San Diego. So where you know that the elbow inflection, the nerve comes anteriorly. So you have to keep the elbow in extension 30 to 40 degrees of flexion, and then you place the thumb over the medial epicondyle, and then that pushes the ulnar nerve posteriorly. And I use the K wire in my hand. I don't put it in the drill and directly go in. I just put the K wire with my free hand into the on the medial side, on the medial epicondyle till I reach the bone, and then I connect the drill and then go ahead with the pinning. So this has worked well in my hands, and there are there are various techniques which is described. Even people say that mini open is a safer technique to put a medial pin. So this is an example of a child with a medial comminution. You can see that there's a quite big fragment on the medial side. And whenever you have this medial comminution, it will be difficult to get the alignment. So in these fractures, a wire in the distal fragment. So like this, a transverse wire helps a lot to get the normal alignment. And you have to put the wire transversely and then pull the fragment into valgus, align it, and then I place the lateral wire. And then we place the medial wire. You can see that I put a thick medial wire since the fragment is quite big. This is a danger sign for us. So, and in addition, I also placed the organ spin to stabilize the medial column, and it went on to heal uneventfully. So this is an example for a comminution on the lateral side. So this is a 9-year-old girl. There is a reverse oblique type of fracture with a huge fragment on the lateral side. So this fragment, this is a medial side comminution only. So this is a quite big fragment, and we were not able to stabilize it with just a medial wire. We plan to do a just fixation. So the just fixator also comes in handy whenever you have comminution. This is just to show a case where you have a medial fragment, a huge medial fragment. You can also stabilize it with a just fixator when you are not able to get a stable fixation with a medial pinning. So this is a child. You don't have to worry too much about the placement of the fragment. You can see that this looks little oddly placed in the lateral view. All that you need is to get the normal valgus alignment, and then you stabilize it with a normal fixator, and then it goes on to heal well. So we also come across adolescent fractures now. So this is a 13-year-old boy who had a fall from bicycle. And this is, again, you can look at the fracture in the distal humerus. It is really badly comminuted, and he also has got a distal radius fracture. So sort of a floating elbow injury. So for this patient, we were prepared for plating actually initially, but intraoperatively we decided that we'll go ahead with titanium elastic nail for the distal humerus and a pinning for distal radius. So when we gave traction and started the tense nailing, you can see actually with traction the reduction was good. So that is when we decided to do tense nailing, antegrade from the proximal humerus. First we passed the lateral nail, and then we again use the same technique to prevent varus collapse. We use a wire and the distal fragment, pulled it into valgus, and then place the medial nail. And this is the sort of final fixation which we got, which was looking quite stable when we tested the stability. It was not going into varus collapse. We also performed an arthrogram to make sure that there is no intra-articular extension, and then pin the distal areas as well. So this is a post-operative X-ray, and this is a 2 months follow-up, which went on to heal well. So whenever you have comminuted fractures, you should think of multiple options in your mind, whichever suits the patient, and particular fracture you should choose. The next
So
group of
Venkat,
fractures is supracondylar. Yeah,
Venkat, just can you go a
yeah,
slide?
Maulin.
Could you choose an external fixator in such geometry of fracture, or what was some
Absolutely.
reason of choosing this?
Yes. No, he was 13. We wanted to do a
A
stable
better fixation.
fixation, and external fixator, whatever said and done, you can't mobilize them early. Whenever there is a comminution, it takes more time to heal on a fixator.
Okay.
So mobilization can be delayed. So that is the reason this is definitely a better option when you have a fracture which is slightly higher up and which is comminuted. If you are able to get a tense nail across, it is not a bad option at all. I feel like this patient had a very good outcome. He's very happy.
And how difficult it was to pass the tens through the pillars, because those are I mean it's sometimes difficult to get to this point. What how did you do it? It's such a nice
The
yeah.
lateral one was quite easy. It just went on smoothly. The medial one was slightly difficult. I was aiming to get this nail into the medial epicondyle. That is actually a more stable fixation. But you may
Hmm.
not be able to get the perfect picture all the time. But it is not as difficult as we think. It's not
Yeah,
difficult. Once because the fracture is reduced, you get a good reduction. Your nail has to go there to the columns because you pre-bend the nail, so it just
yeah.
passes on to the columns. It doesn't miss out. But if your reduction is not there, then it becomes tricky. And there are times where I had to add on a plate on the lateral side. In spite of
Yeah.
putting a nail, it went in for varus collapse. So there was one situation where I had to put additional plate on the lateral side. So it happens
Another
at sometimes.
and another thing is when we put the nail in from the shoulder and someone is giving traction from bottom and someone from axillary, it's difficult to, you know, unlike in femur where we can work on both the sides of femur, here we have only from the lateral side we have to maneuver. It's nicely done. And we always fear that it might break the distal fragment. It's already comminuted fracture, but it's very well done, I think.
Yeah. Okay. So the next set of fracture is the in supracondylar with associated fractures. So this is a child, you can see that there is a small fracture line which is going inside the joint. So you should, whenever there is a comminution, you should always think about intra-articular extension. You should watch out for it. As I showed in the previous case also, we did arthrogram. We always perform arthrogram whenever we suspect intra-articular fractures. So this, I don't have the arthrogram pictures, but this you can see that there is a lot of anterior comminution and there was an intra-articular extension. So we had to do a cross pinning along with, for the intra-articular one, we did a transverse wiring and it went on to heal well. In a slightly older child, again, moving on to adolescence, you still can have intra-articular extensions like this, which you can see clearly in this X-ray that there is an intra-articular fracture. And these fracture are better off with a screw fixation rather than just a K-wire, which allows you to compress and get a nice articular congruity. So the next group of fracture is a rare supracondylar fracture, which is less than 2% in incidence wise. It's flexion type. What is unique about flexion type is that these fractures may require open reduction. They are sometimes difficult to reduce, and you might have to counsel the parents that there might be a need for open reduction in these fractures. And in our experience, we have found that these fractures are often they have a rotational component, and this particular fracture, we were able to reduce by using a derotation wire. We did not open. Just when we rotated the proximal fragment, it fell in line, and then we fixed it. And after fixation, we found that there was an anterior fragment, a comminuted fragment like that, which was looking unusual. So when we correlated the fragment with the AP view, we found that it was a medial epicondyle avulsion. This was a fragment which was looking that anteriorly. So we used a K-wire and uh, reduced it back and fixed percutaneously with a medial wire. So these sort of associated fractures or possible. These are not very common, but it is there can be one rare fracture which you need to be prepared to fix it as and when needed. The next set of fractures are very low supracondylar fractures. So we know that low supracondylar fracture by itself can be difficult to reduce and fix, which are all through the olecranon and fossa. So you can sometimes have fractures on the lower end of the olecranon fossa or even distal to the olecranon fossa. I call it as very low supracondylar fractures, and they can sometimes confuse you. So if you look at the X-ray on the right side, it looks like a lateral condyle fracture. And sometimes they can have a physeal involvement also. On one side, it goes through the physis like a physeal separation, and on the lateral side, it comes out through the metaphysis. These fractures can be difficult to reduce. You may have periosteal interposition, and sometimes you might have to open the fractures to get a good reduction. And also the other important thing in these low fractures are they are pretty difficult to stabilize with your standard wires. Sometimes getting the wires with good divergence can be challenging, and they may need cross pinning all the time. And also you should remember that there can be a vascular insult to the distal fragment, and there is a chance of avascular necrosis of the trochlea. So this particular patient, we thought that it is a low supracondylar versus a lateral condyle. So this was a very recent patient we did last month. So we did an arthrogram, and that showed that clearly that the fracture is, of course, a supracondylar fracture on the medial side. Probably it is coming out through the physis. We were able to get a decent reduction in the AP view as well as the lateral view, and we went ahead with pinning. So after placing two lateral pins, I don't have all the pictures. We checked for stability. So when I did a valgus stress test, we saw that the fracture was opening up from the physeal line. So it was not stable at all. So I was not able to get a good stable fixation with two lateral wires. I attempted a medial wire. I was not quite happy with this sort of opening on the medial side. And then we went ahead and opened medially. So this is the exact point where you can see that the growth plate, there was a periosteal interposition. So once we removed that interposition and reduced the fracture, then we stabilized with two wires. So this was a sort of cross-K wiring which was done. So this is again a very low supracondylar fracture, which might need open reduction. This is yet another atypical fracture. So you can see that it's a flexion type, rare by itself. And if you look at the fracture, it's very low. It is just below probably the olecranon fossa. And my fellow was doing this initially. He was able to reduce, but then he was not able to get a stable fixation. That's when I went inside and then I tried. It was not getting stabilized. Then we decided to open up. We opened up laterally. We found that there was comminution and there was instability because of the avulsion of the lateral epicondyle as well. So we had to suture it and then fix the lateral column. And medial reduction was also not satisfactory. So this is a patient where one of those rare instances where I had to do dual approach. On medial side, we opened up and then fixed the medial column. So after fixation, we found that it was stable. And you also should remember that whenever there is a struggle for fixation and when you make multiple holes in the through the skin into the bone, so it is better to bury the KY. So this patient, because we have burned the fingers previously, when you have difficult fractures and when you have multiple attempts to fix, there is a high chance of pin tract infection. So we decided to bury the KYs inside. And there's one at 3 weeks, we started mobilizing this child, and at 6 weeks, the elbow was really stiff. At this time, we took her in, and then not at this time. At around 5 months, we took her inside, removed the wires, and then we did a manipulation under anesthesia, and we could get up to 30 to 120 degrees. But you can see the shape of the distal humerus. There is a slight lateral subluxation of the the radial head, and it is not looking good. So this is again, I feel that it is not a supracondylar. It is probably a sort of a transcondylar fracture, which is below the olecranon fossa, and these fractures are very difficult to reduce and fix as well, and you should always counsel the chances of elbow stiffness and avascular necrosis. So this is the final outcome of that particular child, and you can see that the child is left with a deformity of about 20 to 30 degree of fixed flexion deformity, and their functional range is there, but still this is not a sort of outcome which the parents would be very happy with if you have not counseled the parents beforehand. So it is very important that whenever you see these fractures, you counsel the parents very well. The last category of fractures is a multidirectionally unstable fractures. Again, this is a 4-year-old child, type 3 supracondylar. I asked my registrar to do it, and he did the usual maneuver of annealing the fracture in the coronal plane and flexing the distal ligament, and this was what was seen. So from an extension type, there became a flexion type fracture. So we had to extend the limb and then fix it. So why did this happen? So these are type 4 supracondylar fractures where your posterior periosteum is also torn. So when the posterior periosteum is torn, when you do a hyperflexion maneuver, the distal fragment is going to flex. So this is something which you need to think about when you have certain fractures. And is there any way how you can predict biological signs which was described? So this was a paper in 2019 in JBJS. So they described these 4 radiological signs, and they have also found that there is a lot of overlap between flexion type fractures and type 4 fractures when there is a flexion angulation or when there is a valgus angulation. So you can see here when you have a valgus angulation or a complete lateral translation or osseous apposition like what is locked here. So these are all the 4 radiological signs when you have where you should suspect that this could potentially be a type 4 supracondylar fracture, and you should be prepared for appropriate reduction maneuvers and pinning. So all this, what I've discussed in the last 15-20 minutes, we have written up already. Most of it is written up in this narrative review article, which was published in the Journal of OASIS some time back. And if anyone is interested, you can read up this article with the case examples. So why do we need to identify atypical supracondylar fractures? So it's like any other fracture. Is there really a need? Of course, there is a need to identify these fractures because as surgeons, we always need to prepare ourselves. We should know what is in store for the day. So when you prepare, you will be able to do better, right from telling the theater that there might be a need for open reduction, keep things ready for open reduction, and also the implants, like if you have to use a fixator or tense nailing. So preparation is definitely helpful. And as surgeons, we know that planning is also important. So when you know better about the fracture, you can as well plan your surgical steps and fixation methods. And the third part is that as surgeons, our job does not end after fixing the fracture. So we also need to follow up the patient. So we have to prognosticate the fracture. We need to tell the parents. We all deal with parents most of the times than the patients directly, who ask a lot of questions. So it is important to prognosticate each fracture and tell them that this is a possibility. This is not the routine supracondylar fracture which we are seeing. So whenever you see an atypical fracture, you need to spend more time with the parents and explain them the possible problems, need for open reduction as well as AVN and stuff like that. So to summarize, so we saw that rotationally unstable fractures, whenever there is an opening up an internal oblique view, so you can reduce them back with the derotation wire, add a medial pin or a third lateral wire. Reverse oblique fractures, again, you cannot stabilize with 2 lateral wires. You can use either a Dorgan spin or a standard cross pinning technique. And whenever you have comminution, remember that those 2 X-rays, medial comminution is always a danger sign. You have to add on a medial pin, and different levels of comminution might need different types of stabilization, like just fixator, tense. I have not put examples for plate fixation, but we do have used plate fixation for certain fractures, particularly in the adolescent age group between 14 and 16, where you have fractures which is extending intra-articularly. So plate is definitely an option. And whenever you have an intra-articular extension, arthrogram is very helpful. And again, in adolescent fractures, CT scan is very useful to look at the fracture anatomy. So you should be prepared for using open reduction, screws or plates as if needed. And very low supracondylar fracture, you should be aware of that they could be really problem fractures, both in terms of reduction and fixation, and also the terms of avascular necrosis. And finally, type 4 configuration, whenever you see unusual fractures, you should suspect type 4 and then plan for reduction accordingly. Thank you.
Yeah. So, Venkat, that was a great talk, as usual. So, the question from Tashween is, yeah, in the internal view, there is rotation. Then what are the tricks and tips to correct that? To answer that.
Yeah, that's a great question. See, most of the times in external rotation, it reduces. So if it reduces in external rotation, so you can keep the limb externally rotated and add a medial pin. So any technique, whatever technique feels comfortable to you, you can add a medial pin and then check. If you are not able to get the reduction, we put a derotation wire in the proximal fragment is what I do usually, and then rotate it back to get the reduction and then add the third pin. I always prefer a medial pin when there is a rotational instability. I don't try with the lateral pin.
Yeah. Okay. So we see lots of patients try to be reduced by adult surgeons and then they fail and they send it to us. So what are the indications of open reduction in your practice and what approach you prefer, Venkat?
There is no set indications. I would say that I don't go with the mindset of that I'm going to open this fracture when it is a fresh fracture. So we will do all the tricks and use all the tools to reduce it closed. So whenever I feel that I'm not able to reduce, then definitely I open. The second area is when I'm not able to get a stable fixation. I've seen that we are able to get the reduction, but we are not able to stabilize it with two KOS. It looks, you put two wires and then it looks still unstable. You're not happy. Then that is a case which I came across recently, the last month case. Though I was able to reduce and fix it, it was unstable. So those fractures, I feel that it is better to open. And the approach depends upon where the spike is, where the problem is. So no posterior approach. I've never done posterior approach for getting reduction, except in those patients who I was planning plating. So either it is lateral or medial approach.
So that's
And of
the
course, if you have a vascular injury, it is a straightforward
anterior
anterior
approach.
approach. Yeah. Yeah.
So that one piece of advice to all our adult colleagues who are in this group, they are well versed with the posterior approach. So we see lots of open reductions done by posterior approach and anteriorly they are not well reduced. So anterior approach is also not difficult and you are approaching directly the vessels. We have fear, but we have to embrace them. A lot of people who ask what should be an approach if we find post-operatively that there is ulnar clawing. So Venkat, what is your
Preoperatively, it
approach?
was not there, and postoperatively,
Uh-huh.
the patient is. So if you have
Yeah.
put a medial pin, definitely you need to take out the pin. There is no doubt about it, and wait and watch whether it is going to go, because it is not, most of the times you don't go through the wire. It is actually because of the rotational movement. There is a sort of neuropraxia and it will recover. Usually we wait for about 3 to 4 months time to see the signs of recovery. And if it is not recovering, definitely there is an indication to explore. So 3 to 4 months is the time duration we give before exploring these nerve injuries. Even if it is pre-operatively, there was a nerve injury, the same principle holds good. You look for signs of recovery for a period of 3 months. And if it is not recovering, definitely there is a role to go ahead and explore the nerve.
And we should check the reduction should be 100% anatomical. Like if you find
Yes.
something is, then you open and make sure.
Yeah. So
it's
that
not.
is post-operatively, if you it is not seen usually with the ulnar nerve. We come across with medial nerve usually that gets entrapped in the fracture site. So whenever you see medial nerve signs post-operatively, you should open. So you can't wait. When you see that there is a preoperatively the nerve was okay and postoperatively the median nerve palsy is there, it is always an entrapment unless proved otherwise.
And lots of time we see the anterior pucker sign with contusion. And when you try to reduce, you
Yeah,
don't feel crepitus. What is your technique in that, Venkat?
anterior pucker sign. When you try to reduce, you don't feel
The
you're not
crepitus
able to
of the bone,
reduce.
and there's probably muscle interposition.
Yeah, so we try with the milking maneuver first. We try to milk the brachialis and see whether it goes back in place. And if it doesn't go back in place, if the fracture is amenable for a posterior joystick, I use a KY from the posterior side and try to reduce. I do not go in anteriorly directly. So there are techniques where you put a suction tube and get evacuate the hematoma and push it inside. So most of the times I've been able to get away with either a milking maneuver or a posterior joystick. And off late for those patients who are having no doubtful pulse or pulseless supracondylar, we directly tend to open. Yeah.
So how would you milk the brachialis? Can you show just physically the technique, what you do in that?
Yeah, you know that you'll be, what happens when there is anterior pucker is you'll be able to feel the spike of the bone, a subcutaneous plane. So you gently ask your assistant to give a gentle traction and then you try to gently press the brachialis down and then you go down to the tip of the fragment and try to push the fragment inside. So
Yeah.
by that maneuver, you most of the times it falls back in place. But
What
again,
I
every
yeah,
fracture is different.
yeah.
You,
What I've seen is a few patients, like adult colleagues, they try to reduce and they fail to reduce and they send it over. And when we give a proper relaxation under general anesthesia, it's very
yeah, it
easy
falls back.
to, yeah. So probably they use ketamine or something. They don't use enough relaxation, and that's the reason why these muscles. So for adult
I mean,
colleagues,
I don't know whether fortunately or unfortunately, we don't see this sort of failed reductions in our part of the country. Either it is reduced and fixed,
oh
or
yeah,
you come as a fresh fracture.
yeah. But
So
we,
that's how it is.
yeah, yeah. Some of our
But it is
colleagues are,
good. Yeah, it
they
is
are they
good
are good actually.
that
They tried
people,
and
if they
they,
are not able to reduce, they are referring it. It's very good.
yeah, yeah. They just communicate with family that we tried, but it's not working. So you go to a. So I admire and respect those colleagues.
Yeah.
You want to talk a bit about how do you do arthrogram just for the information of fellows and what approach and
Yeah. So
dilution?
arthrogram, usually through the posterior approach, I use the regular IOXL dye in 50-50 dilution, 50% dye and 50% normal saline. And you feel the tip of the olecranon and just go proximal to that. You go directly in the midline posteriorly, you will be inside the joint. And it's a very straightforward and simple procedure with it's not at all difficult. Previously, we used to go through the lateral approach, just proximal to the radius there. But that is a little more tricky, particularly when you're having a lot of swelling. It is very difficult to get inside the joint through the lateral approach. Posterior approach is very predictable and it's very simple to do. To palpate the
You,
olecranon fossa and just go above the olecranon. I mean, olecranon process and just go above the olecranon process into the olecranon fossa, and then it's always intra-articular. Your olecranon fossa, you inject the dye. You can aspirate, look for blood, and then inject.
so that's a good thing. I used to go between radial head and olecranon, but sometimes
Mm.
you're not sure whether you're in the joint or not. So that's a good technique. Now, I ask all the fellows to read your paper about pink pulseless hand.
Okay.
The nice paper published in IJO, and I thought you would talk about. But can you
IJPO.
IJPO? Yes.
So you want to
So
cover the pink pulseless hand
yeah,
also?
if you have a presentation, that would be great. And if not, then you can give a bit commentary on it because
Let me
that's
just
a
check.
nightmare for lots of fellows and adult colleagues. And you know,
Yeah, I'll have a presentation. I'll just check 1 second.
yeah, if you have, that would be great because we don't have any cases. We just have. If we have 5 minutes, then Preksha will present. We presented it last week, but this is a new fracture
Okay,
pattern which we have noticed, and she'll share her presentation. But once you
sure.
finish with,
I So you want me to present first or she goes first? How is
yeah,
it?
yeah, you first present this pink pulseless hand.
Okay. So the latest presentation which I have is from last year, 2024, 2023, right? Okay, I can share the presentation. It's a small one. I'll go through it. No
Yeah,
problem.
yeah.
Okay, so as rightly pointed out, this is always a burning issue. Whenever you discuss about supracondylar fracture, it doesn't end without talking about pink pulseless hand. Due to many reasons. One is there is no strong evidence. So because the injury itself is not very common, so there's no strong evidence from a single center perspective. And what we have is always meta-analysis and the systematic reviews. The second important thing is whenever there is a mismanagement, it's going to be a disaster for the patient and it will end up with lifelong disability. And third is the legal issues where you can have problems when you end up with compartment syndrome or VIC. So I'll start with this case, who's a 5-year-old boy. So initially, he was diagnosed as pulsar supracondylar at local facility, and then was referred to a higher center where close reduction and percutaneous spinning was done. So this is not the immediate post-op X-ray, but this is I think done in the second place. After the pinning, there was no return of pulse. The surgeon felt that the limb was pink, so it is like the pink pulseless hand, and he labeled it as pink pulseless hand and decided to observe. So unfortunately, after 24 hours, the limb was found to be cold. So at that time, exploration and vein grafting was done. And the patient came to us 2 days later with a complete gangrene of the uh, forearm as well as the hand. And obviously, they ended up in an amputation. So this is something which you do not want to happen. So we should understand the difference between perfusion and pulse. So we have to understand that perfusion is more important than pulse. But having said that, we need to assess for perfusion of the limb. So is there any uh, objective way to assess the perfusion of the limb? So by the term, we mean pink pulseless hand. It's actually, we talk about pink perfused pulseless hand. So though there is no pulse, the hand is well perfused. That is why when you decide to observe. So, but if you look at this review article in 2023, it's a very nice systematic review. They have concluded there is no objective criteria to assess perfusion of a limb. And there is the evidence base in this area is very limited and further research is required. So what is our protocol? We assess the perfusion. When you have a good perfusion, you can have two different scenarios. When you have a pulseless supracondylar, one side you have a limb with a good perfusion, the other side it's a doubtful perfusion. For all those with good perfusion, you do immediate close reduction and pinning. And you should remember that it is not a good idea to wait till next morning like any other type 3 supracondylar fractures. And those with doubtful perfusion, again, the initial treatment is going to be the same. It's immediate close reduction and pinning. But I would recommend that whenever you are dealing with pulseless supracondylar fractures, it is better that you have a vascular surgery backup in case if it is there is a need. You should be able to send the patient for a vascular exploration, either within your facility or in a nearby facility. So this is important to remember between these two groups.
So
So whenever
Venkat,
there is, yeah,
What is your definition of good perfusion and
yeah,
doubtful
I'm coming
perfusion?
to it. Next slide itself
Okay,
is coming.
okay.
Okay. So this is sort of our experience in pulseless supracondylar till 2020. Out of 448 fractures, we had around 66, about 15% of them. So that's what I always say. Atypical supracondylar fractures is 10 to 15%. Again, pulseless supracondylar fractures is 10 to 15%. So you should always remember these numbers. But it's like 1 in every 6 or 7 supracondylar fractures can be problematic. So after close reduction and pinning, we had return of pulse in only 30% of them. And then it's only 18% patients the pulse came back. In the rest of the patients, there was no return of pulse. The 73% of them, the pulse did not come back. So in those group, so how we assess the perfusion? So we I'll come to that point in the next slide. 40 of them had good perfusion. We decided to observe all of them, and the rest 8% who had poor perfusion had exploration. So the rate of exploration is like around less than 20% in those pulseless zones. So assessment of perfusion, these are the three things which we use. Capillary refill time should be less than 3 seconds, the CRT. The second thing which I found very useful is the SpO2 signals, which should be more than 95% and with good waveforms. That is again important. Third is handheld Doppler, which is very useful. Let us look at each of this. So this is the CRT which we are talking about. You can see that immediately after release, there is filling of the pulp. This is a good perfusion. You know that the saturation is 100% and good waveforms is there. And this has also been published from Singapore, that SpO2 signals are good to assess perfusion. And third is the handheld Doppler. This is a very handy tool, which is not very expensive. You can have it in your OR or ER, and you can look for the Doppler signal. So this is actually the ulnar artery signals. Whenever you don't palpate the radial artery, you can use for look for radial artery as well as ulnar artery. Sometimes we have found that the ulnar artery signals you'll be able to pick up, and that is again an indication that the limb is perfused well. Right? The literature is divided on this, and there is no clear guidelines of when to explore. And if you look at all the explorations which we have done, for all the patients, the radial artery Doppler was negative. Doppler signals was negative, and pulse oximeter signal was less than 80. The oxygen saturation was less than 80, and they had irregular waveforms. And 5 out of the 8 patients had associated median nerve injury. On exploration, 6 of the patients had just kinking of the vessels at the fracture site. Only 2 patients had direct repair. I mean, one patient had a direct repair and one patient needed a vein graft. So this was old data. And whenever there is this other thing, that whenever you have a pulsar supracondylar fracture with the median nerve injury, people favor more of an exploration, but that was not the observation in our series. We had 21 median nerve injuries, out of which 40 patients had observation only. About 75% of the patients did well with observation. So a more recent paper on that, again, the same finding, that if you have a median nerve injury with pulseless supracondylar fracture, it is not an absolute indication for exploration. You can still observe as long as the perfusion is good. So that was the message. So what are all the definitive indication to explore? A poorly perfused hand that remains poorly perfused after close reduction and percutaneous pinning. So whenever the patient comes with a pulseless hand, you assess the perfusion. You see that the perfusion is bad. You take up for a pinning. And after pinning also, the perfusion is still not improved. Then it is definitely an indication to explore. The second group is a well-perfused hand that turns poorly perfused after CRPP. So this is not uncommon in our practice, at least. We have seen that in the emergency, the saturation will be good, the waveforms are good. You take them to the OR, do a close reduction and pinning, and after pinning, we found that the saturation is not picking up, the waveforms are not good, Dopplers are not picking up. So we have faced that situation couple of times, and this is definitely again an indication for you to open up and explore the vessel. And we have found that there was some issues all the time. So this is a case example, 8-year-old male who had a pulseless supracondylar, close reduction and percutaneous pinning was done. And on the right side, you can see, for comparison, I put, you can see how this is how a pulseless, poorly perfused limb, you will not be able to see the waveforms and saturation is not picking up. And I will show the video of the CRT as well. So clearly it is not filling up compared to the right side. You can see that CRT is prolonged on the left side. So you're not happy about the perfusion. So there is no Doppler signals, there is no CRT is prolonged, and your SpO2 signals are not good. So this is definitely a poorly perfused hand, and it is an indication to explore, and that was what was done. Repair of the brachial artery was in because there was a thrombosis. So whenever you have a pulseless supracondylar fracture, the strategy is in emergency close reduction and pinning. So there are times where we have found that you just reposition and then put a back slab in 30 degrees flexion and assess perfusion. We should also think about vascular backup, vascular surgery backup when at this situation. And after pinning, if there is a return of pulse, it is a routine care. And if there is no return of pulse, you will have to reassess perfusion. If it is well perfused, it is inpatient observation. There is no role for daycare surgeries. You will have to keep them in-house for 48 hours at least. And whenever there is doubtful perfusion, you will have to explore. Yeah.
Yeah, so that's a great talk. Now, Venkat, many of us have, of course, we check through pulse oximetry, the waveform, and we see the capillary refill. Now, if we are happy with the waveform and the capillary, then do we need to do the Doppler?
It is optional, Maulin. If you're
Yeah,
happy with the perfusion, your refill is good. And see, saturation,
yeah,
and if it is more than 95%, most of the times, almost all of the times, we have not had any problems. It's a very good
mm,
tool, but unfortunately, it is underrated, particularly because there is no probably literature from the West. In the West, the situation
mm.
is different because they always say that no, there is hypothermia. By as such, the weather is very cold there, and pulse oximeter signals may not be the ideal way to assess the perfusion. But in our country, I don't think that is the situation. It is a very good tool to assess the perfusion.
Another thing is like we see pulseless pink, and we know that this is a well perfused due through collaterals. So
Hmm.
even with Doppler, if we don't see the flow through radial artery, then also it's okay if it is well perfused through ulnar artery and collaterals. Isn't it true?
Exactly, exactly. Always it is the collaterals. That is why we do not do the Doppler of the brachial artery. So if you do the Doppler of brachial artery, almost all the time you will see a block at the elbow level of the fracture site. So it is the collaterals which is giving the perfusion for the forearm and the hand. And as long as the perfusion is good, it is okay. And this handheld Doppler may not be able to pick up the signals all the time. And
Hmm.
the duration is also important. So after close reduction and pinning, we give a good at least 20 minutes time before decide to exploration. So we
Exactly.
actually warm the limb, reposition it. Sometimes if you keep in abduction also, we have seen that the pulse is not there. You bring it to normal shoulder position, the pulse comes back. So
Yeah.
you don't decide it instantly. You give some time, you warm the limb nicely, and then if
Yeah.
in next to 20 to 30 minutes, if the pulse doesn't come back, then only not the pulse, if the perfusion does not
Yeah.
satisfactorily improve, then we think about
Yeah.
exploration.
So I
Yeah.
had a similar experience. So there was a pink pulseless limb with doubtful perfusion, and we did the close reduction. And I informed my the vascular surgeon colleague that I might need your help. We fixed it, and still the perfusion was doubtful. And so I called him up. That patient is under anesthesia. You want to come and explore? And he said that I'm away sometime, but maybe your maneuver might have got the spasm. So you wait for some time and bring patient out of anesthesia, and I would like to check after an hour and then to take a call. So that's what we did, and in half an hour, everything came. The
Came back.
perfusion
Yeah.
came, the pulse oximetry. So
Yes.
so there's another message. This is very important message, Venkat. You wait for some time. Many a times our maneuver of reduction might have also caused a
Cause
spasm,
the
and it
spasm.
might,
Yes.
yeah. So yeah,
Maureen,
that's a
So we
yeah. So Dr.
yeah,
Mukesh
Maureen,
Shah is a very senior orthopedic
yeah, no, it's okay.
surgeon.
Like, can I congratulate Venkat? It's a wonderful paper and very good message for the general surgeons like us.
thank
I
you, sir.
really congratulate Venkat. It's really excellent summarization of your paper and the adding of Maureen that you wait for a half an hour. We had also similar experience long back, and it's an excellent message. Thank you very much. Yeah.
Yeah. So I think we have 5 minutes from finishing. Venkat, we want to share a pattern of fracture. As you're very experienced in it, you can suggest when we are intending to publish it
Sure.
because we have not seen this pattern of fracture. Preksha would like to share your presentation.
Yes, sir.
We will quickly go through and finish in 5 minutes.
Is the screen visible, sir?
Yeah.
Yeah.
So
Okay.
let's go on to the case. Yeah. So this 11 years old boy unfortunately came to us at 2 months post injury, and this is the AP and lateral views. So what I found that the lateral condylar part is aligning well with the radial head, and rest of the
Yes.
humerus is shifted anteriorly, rotated, and it is going through the fossa, and it gives a double fossa sign on AP view. And
Yeah.
this patient was treated as a lateral condyle fracture by lateral approach by an adult colleague, and he
Okay.
probably placed the wires, and he could not reduce it well, remove the wires, and this fracture probably went where it was before. So what is the exact pattern of fracture you read it in this X-ray?
So to me, it looks like a lateral condyle which is going on very medially into the trochlea. Probably it is just medial to the trochlea.
Hmm.
It is not through the physis. It is not like the patient which I showed, no, where there is a physeal
Hmm.
separation
Hmm.
on the medial side because your medial epicondyle looks intact.
Hmm.
So probably the fracture line is exiting just lateral to the medial epicondyle, the medial most aspect of the distal humerus or the medial most
Yeah.
aspect of the trochlea.
Yeah. So it can either be defined as a now we know the Milch types and all the lateral
Yeah,
condyle. The end point is the trochlea
yeah,
and not beyond trochlea, or it's a kind of low supracondylar, which is going very it is higher up on the lateral side and lower down. It's a kind of lateral oblique and low medial, right?
yes.
Now we had an opportunity to do an open reduction for this child because it was 2 months old and not moving at all. So
Hmm.
we could study the fracture geometry very well. Can you go to the next slide, Preksha? Yeah. So if you see, as you rightly said, the fracture line is going medial to the trochlea in the most left figure you can see, and it's not lateral condyle because in usual definition, the lateral condyles they would end up into the trochlea. Yeah. So
Yeah.
this was an kind of extra articular or minimal intra articular piece you can see in the second image.
Yes.
And so yeah, I did it before 10 years and did the olecranon osteotomy approach. I would do something different now, but we dissected the ulna now because I had to put a screw because we wanted
Yeah.
to have in kind of intra-articular compression. But
Okay.
but
Looks
this
good.
this was a fracture pattern, so it's not a pure lateral condyle and neither elbow
Yeah.
dislocation, but it's a supracondylar which starts little higher on the lateral side and it goes way down on the medial side. And so we termed it as a lateral oblique medial low fracture pattern. And then we came across many acute presentations. A couple of them are showing. So this is a 9-year-old with acute injury. And as we can see, the same pattern where the capitulum is with the radius and the rest of the humerus has slided in front. Not a flexion variety, but it's a low fracture, but the lateral condyle is in position and rest of the humerus is gone. Now we applied the same supracondylar reduction maneuver and we could reduce it and fix it with a simple 2K wires
Yeah.
without opening. And one more, so this is a 10 years old. Again, the similar pattern. The lateral condyle part is with the radius and the rest of humerus has gone front. Again, the same maneuver and 3 lateral pins, and it did well.
Yeah. It's interesting. Yeah.
Yeah. So I think P.N. Gupta has published this kind of pattern, but he has mentioned it as a lateral condyle fracture with. Can you go back and show that paper, Preksha?
Yes, sir.
So he has mentioned it as malunited lateral condyle fracture of humerus with elbow dislocation. So when we retrospectively see this paper, the images are matching the pathology which we have been showing. So unless you do an MRI scan, or if you have an opportunity to open, you will not be able to judge where the fracture line is exiting on the medial side.
Yeah.
So maybe as we had fortune or unfortunate to see this by open approach, we must describe it. What do you say, Venkat?
Yes, exactly. I think it's a very interesting pattern of fracture. I'll look up if you have any cases like similar to this what you have shown.
Yeah,
We might
so
have we might have
Vidyasagar,
missed to recognize the fracture pattern as such.
so Vidyasagar last week when I showed, he shared me one case where he had in like this, and he had this dilemma, but he could reduce it well. So you'll have this kind of picture where the lateral condyle is radial head and the rest of them is moved in anteriorly. And the message is we can treat it like supracondylar. We don't need to open. It's not lateral condyle. It's a supracondylar with a very low medial exit. That's so Venkat, that was a great session, and I always learn new things when I listen to you, and I'm sure the fellows and all senior orthopedic colleagues would have learned a lot. Soma Raju, so and Anirban, it's a similar to type 2 supracondylar humerus.
Salter Harris. Type 2 Salter Harris
Salter
injury.
Harris, yeah, that's right, Anirban. And Soma Raju has also seen this pattern. Seen this fracture only once. I could not place the medial pin, which is always my first. Used 3 lateral, but ended up with an ulnar nerve injury. Okay. So it was an iatrogenic ulnar nerve injury. I mean, a non-iatrogenic injury. Yeah. So thank you, Venkat, for your time. And we all
Thank you,
learned a
Molin.
lot.
Thank you. It was a
Yeah.
pleasure.
Yeah.
Bye.
Bye-bye.
Good
Take
day.
care. Have a good day. Thank you, everyone, for joining. Thanks, Anirban, and everyone for your time. Have a good day.
Bye. Thanks.
Bye-bye. I'll talk to you, Anirban. I'm coming to Kolkata.
Oh, when?
I'm coming in March, I think March 3rd week or so. I'll call you and
Okay.
want to
Great.
fix up few things and have your guidance.
Sure. No problem.
Yeah.
Chalo.
Okay. Take care.
Okay.